All right, guys, so today on Road to 250, I'm going to talk about H. pylori, Thiazolidinediones, and von Hippel Lindau. So to start off with, H. pylori, one that we've gone over several times, but always good to review, is a curved bacteria of 3. Can anybody tell me what are the other curved rod bugs?
Campy.
Yep, campy and
Shigella. Yersinia?
No.
No. Vibrio?
Yeah, Vibrio. So your 3 curved rods, gram-negative, are H. pylori, Campylobacter jejuni, and Vibrio. So H. pylori has this triple effect in terms of its characteristics, being that it's catalase positive. What does catalase positive, what is it characteristic of, and what type of patients, are you really concerned?
Chronic granulomatous disease.
Yeah, exactly. With chronic granulomatous disease, as they have recurrent infections. So one of these infections could be H. pylori, as it's catalase positive. It's also oxidase positive and urease positive. What's a diagnostic test that we can use for H. pylori?
Breath test. Urea breath test.
Yeah, exactly. The urease breath test, or you can do the fecal antigen test or toxin assay for diagnosis. So the importance of the urease positive and why it's a reason for why the urea breath test can be used is that urease produces ammonia, and that creates an alkaline environment, which helps the H. pylori thrive in the mucosa. And so with that, in the breath test, if it's detected, we can almost use it as a diagnostic. But the most accurate test for diagnosis of H. pylori is actually biopsy. And I am going to go over that in a little bit. But to continue, where does H. pylori mainly colonize within our organs?
Antrum?
Yeah, antrum of the stomach, and that's quite characteristic as well. And so H. pylori also causes gastritis and peptic ulcers as a result, especially duodenal. And risk factors are going to be peptic ulcer disease, gastric adenocarcinoma, and malt lymphoma, as the carcinomas are cancerous risks that can rise. And then lastly, treatment. So what is the general indication for treatment?
Triple therapy.
Yeah, triple therapy, exactly. So the initial triple therapy usually consists of 2 antibiotics and a proton pump inhibitor. So amoxicillin and clarithromycin plus the proton pump inhibitor. However, if you have a patient who has penicillin allergy, you can replace with metronidazole. Also, one thing that they did not mention in this first aid piece here is that H. pylori can also be part of the silver stainers. So that was one thing. Okay, so a little bit more about treatment and management. So if we had a patient who's a 40-year-old female, has epigastric pain, and the doctor does an examination and has diagnosed her with a gastric ulcer, and then to confirm the diagnosis on biopsy, the doctor sees no malignancy, and she is positive for H. pylori. So like I said earlier, biopsy is the most accurate test, actually, and then the stool toxin assay and urease test are definitely diagnostic, but not as accurate as the biopsy. And obviously on biopsy under microscopy, you would just see H. pylori. So a little bit more about the treatment. Like we said, 2 antibiotics, clarithromycin and an amoxicillin plus the PPI. So the adverse effects that we want to keep in mind with these are going to be the fact that there is going to be an increased chance of C. diff, colitis, and aspiration pneumonia. However, does anybody know if this initial therapy fails, what could be the secondary therapy?
Tetracycline, metronidazole, and bismuth.
Exactly. So if it fails, you can do the proton pump inhibitor with bismuth subsalicylate and 2 different antibiotics, and that being tetracycline and metronidazole. And then, does anybody know what's the significant, or what bismuth does? Mechanism of action, what's its purpose, and how does it act therapeutic?
Neutralize the acid?
Kind of. It's pretty simple. It's just anti-inflammatory, and it just creates a protective barrier at the base of the ulcer. So, I guess so neutralizes in that sense. And to keep in mind, an adverse or something that occurs as a result of taking bismuth is that bismuth is actually insoluble. Bismuth subsalicylate breaks down or becomes metabolized into bismuth sulfide, and that is insoluble. And so the patient is going to then have black stool, and they can also have black tongue. So that could be like an adverse effect. And then I guess if you have a patient who does the idea is that the stool would be heme and guaiac negative, confirming that it's as a result of bismuth intake and not something else. So that kind of sums up the H. pylori. Does anybody have anything to add or comment on?
Nope.
All right, cool. So the drug of the day is the thiazolidinediones. Can anybody tell me what the main idea of the mechanism of action is? What's the enzyme or
PPRY or PPR gamma?
Yeah, so the receptor is that the thiazolidinedione binds to a PPAR gamma nuclear transcription factor, and that is increasing insulin sensitivity and levels of adiponectin, which then leads to regulation of glucose metabolism and fatty acid storage. And can anybody tell me, a common side effect or adverse effect of this drug?
Edema?
Yeah.
Weight gain?
Yeah, weight gain and edema. And then heart failure, and then there's increased risk of fractures as well. So to kind of go into a little bit of detail, indication, obviously type 2 diabetes mellitus. And as we said, the mechanism of action is that it increases the peripheral insulin sensitivity on muscle, adipose, and liver cells by activating the PPAR gamma, typo, receptors. And its adverse effect is going to be increased weight gain. And like any oral or anti-diabetic drug, it's going to be hypoglycemia as well. And the idea behind why weight gain, does anybody know?
It's not from the water?
From water retention? Yes, but also something else. And being that insulin is increased, it's increasing insulin. Insulin is increased, and it's goes off of that.
Glycogen or something like that?
So insulin drives fat acids into cells, and so it's kind of also increasing the fatty acid accumulation in that sense too. So one thing that, so in general, thiazolidinediones are kind of a drug that we're going to use in caution because of its toxicity, and that being that one of its strongest contraindications is if you have a patient who has CHF because of that fluid retention, and that could throw them into like fluid overload, exacerbating and then causing heart failure. So pretty much it's more like a third or fourth line drug therapy, or maybe like an add-on with a first line drug therapy. And then to give a little bit of a better idea about its mechanism of action, essentially it decreases, so thiazolidinediones decrease insulin resistance by binding to the PPAR gamma receptor, which is a transcriptional regulator of genes involved in glucose and lipid breakdown. So when the thiazolidinedione drug binds to the PPAR gamma receptor, it causes like a conformational change. So the relationship is like a ligand binds, and then gene expression will occur. And with this whole activation, so pretty much this complex here with the thiazolidinedione, the yellow triangle, and then the receptor, it will then bind to the transcription regulatory sequence of the gene down here, and then cause like glucose and lipid metabolism. So important genes, I thought this was good to make note of. Genes that are altered by this receptor is increased adiponectin, increased fatty acid transport protein, increased insulin receptor substrate, and then increased GLUT4. So that's kind of what I have for the thiazolidinediones. What are some of the drug names for this class?
Pioglitazone and rosiglitazone.
Yeah, it was on the previous slide, but yes, pioglitazone and rosiglitazone. So yeah, I think that's all I got. Anybody else have anything to add? It is a drug that takes like a couple weeks to really show improvement in the levels, hence why it's more of like a third or fourth line drug.
I had a question on this on my test.
Oh, yeah?
Mm-hmm.
Do you remember what?
Yeah, they were asking of the drugs listed, which of them works in the nucleus.
Oh, okay. Yeah.
So.
Cool. Alrighty. Anything else? Anyone?
No.
Alrighty. So concept of the day is going to be von Hippel Lindau. So the big picture of von Hippel Lindau is that von Hippel Lindau gene mutation occurs, and as a result, it disrupts the ubiquitin ligase complex. And the disruption of the ubiquitin ligase complex causes an accumulation of HIF1A, which is hypoxia-inducing factor. And so like it says, hypoxia-inducing factor, it induces, therefore, the transcription of a variety of genes such as VEGF, EPO, platelet-derived growth factor, and TGF-alpha as a result of angiogenesis, because we're inducing this hypoxic state, and so now the body is going to have a response of angiogenesis. So that's the big picture. In terms of diagnosis, I guess it's pretty simple. If you have a patient who has family history, plus the finding of hemangioblastoma or renal cell carcinoma, that would pretty much solidify your diagnosis, and I'll explain why in a second. And also in these patients, they can have history, or you can see pheochromocytoma symptoms as well. So as first aid says, to give you guys a little bit of better picture of what a patient with hemangioblastoma would present as, this is going to be often cerebellar. So it's a hemangioblastoma is going to be an adult brain tumor. And pretty much they have they'll have the increased EPO, and that kind of goes in hand again with why it's related to von Hippel Lindau and its mutation. And you're going to see closely arranged, thin-walled capillaries with minimal interfering parenchyma. So essentially, like lots of capillary blood vessel building up. And then for renal cell carcinoma, you're pretty much going to have like a patient who's maybe going to say, you know, they're going to have hematuria, palpable masses, polycythemia, flank pain, fever, weight loss. So patient with some history of those symptoms can indicate they might have renal cell carcinoma. So does anybody know what chromosome the VHL gene is located on?
Chromosome 17?
Mm-mm.
3.
Yeah, exactly.
That's
It's
right.
chromosome 3P. 3 letters, VHL. You can use that as a way to remember it. And what is its mode of inheritance, which also explains why family history can be diagnostic.
Autosomal recessive?
It's autosomal dominant. So if they have a parent who has history of it as well, then it would make sense why they would also have it. So, like we said, it's a mutation in the ubiquitin ligase, which then causes increased transcription of hypoxia-inducing factor 1A. And it's pretty much characterized by development of numerous tumors, both benign and malignant. And you can remember the specific findings or pathologies by the mnemonic HARP. H for hemangioblastoma, so high vascularity with hyperchromatic nuclei, can be seen in the retina, brainstem, cerebellum, or spine. And I guess that's why earlier for the hemangioblastoma, it was more so saying associated with von Hippel Lindau when found with retinal angiomas. Well, yeah. And then the angiomatosis, so the, for example, cavernous hemangiomas seen in the skin, mucosa, organs, and then bilateral renal cell carcinoma and pheochromocytoma, P for P. So, yeah. And that is everything I have for von Hippel Lindau. Anybody have anything to add on? Questions?
Can review?
Okay, so I have questions for you guys. All right, so the first one is, a 65-year-old man presents to the office with complaints regarding his urine. He states that he has recently had bloody urine but does not have any urinary pain, hesitation, dribbling, or increased frequency. He also says he has lost 4.5 kg or 10 pounds over the past 2 months. A biopsy of the patient's bladder wall is shown in the image. Oh, sorry, I forgot to add the image. The patient reports that he has never traveled outside the United States. Which of the following risk factors has the strongest associations with this patient's disease? Yeah, essentially, I think the key is just bladder wall, so still should be okay without the picture. So A mutation in the VHL gene on chromosome 3, B, a mutation of the WT1 gene on chromosome 11, C, history of another primary tumor, D, history of heavy cigarette smoking, and E, history of schistosomiase infection.
It's D, right? Because smoking is associated with the renal cell carcinoma.
So, yes. Well, I guess I didn't give anybody else a chance to say anything. Yeah, exactly. So, right. The answer is right. Yeah, history of heavy cigarette smoking. When I approached this question, I kind of initially jumped the gun and forgot to really think about the fact that they were saying bladder wall. And so it kind of tricked me in my rush of answering the question. But yeah, so really the patient's has transitional cell carcinoma. So hence the answer would be the heavy cigarette smoking, as they said that he has not traveled outside the United States. So, yep. All right, next question. A 56-year-old male with type 2 diabetes mellitus is treated with pioglitazone. 2 weeks after initiation of therapy, there is no meaningful improvement in glycemic control. You soothe the patient's concern that this new medication just isn't working by explaining that the mechanism of action of the drug involves which of the following? A, hormone secretion. B, decreased glucose absorption. C, receptor downregulation. D, enzyme inactivation. E, transcription modulation. Yeah, exactly. Yeah, so it's pretty straightforward after reviewing the thiazolidinediones.
You told a patient, "Oh, it's transcription modulation." They'll be like, "The fuck are you talking about?"
Right, exactly. I'll probably be like, "Yeah, you're still wrong." All right. One last question. So, a new drug is being developed for the treatment of diabetes. This drug is activated by the peroxisome proliferator activated receptor gamma, a nuclear receptor and transcription factor. Activation of this receptor would most likely result in which of the following? A, downregulation of leptin activity. B, increased insulin release. C, decreased insulin resistance. D, increased free fatty acid levels. E, downregulation of adipomectin.
C.
Sorry, what did you say, Divya?
C.
D.
D.
C.
Okay. So I got a B, C, and D.
Yep.
All right, so it's going to be C, decrease insulin resistance.
Increases the sensitivity of insulin.
Yeah. Right, yeah, exactly. So, tricky question there. And that's all I got, folks.